posters. So we're going to talk about spine first. When I look at the spine from the front, it should be straight. We shouldn't see more than about a 5 millimeter shift of the spine to the left or the right off the midline of the tailbone. When we look at the spine from the side, we should see that your head sits squarely over your hips, and in between there should be 3 equal 40-degree curves. Okay? Now the curves do a couple things. Number one, they provide like shock absorbency to absorb the weight of your head and your body. But number two, an arc is very, very strong, correct? So that provides strength in your spine. And then very importantly, your brain sits in your skull, but it sends your spinal cord, which is really an electrical wire, down through the center of your spine. The curve is what makes up that hole. So the curve allows there to be a nice open hole for the spinal cord to go through, and then the individual nerves bring strength and energy into every single vertebra in the body. So we can see something happen called a subluxation. Have you heard of that before?
No.
No, okay. Does anybody have an issue with the word subluxation? If you do, say fixation or lesion, whoever you are, I mean, I don't care. We proved in CBP that subluxation is present, what it is. Whatever word you're going to use, it doesn't matter. So subluxations can happen in the spine. They can happen gradually, like poor posture over time, or suddenly, like in a trauma. Now, if we move a vertebra or a region of vertebra out of alignment, that can affect the curve or the alignment from the front. That can not allow strength and energy to flow in your body. That can not only cause pain, but other types of health conditions. Does that make sense? Okay, so in the low back, the nerves that come out of the low back, they go into the bowel, the bladder, the reproductive organs. Those nerves go all the way down into the legs and into the feet. So if you have a low back condition, sometimes we see people have diarrhea or constipation. Are you having any of that?
No.
Have you ever had any of that?
Yeah.
Okay, you have. And then how about urinary issues? Any post-urinary dribbling, difficulty initiating stream? No. And then of course we've got to ask about sex. You're going to ask about sexual function. It's totally uncomfortable for everybody, but it's also totally important to everybody. Ask about it, give the information. They're going to tell you. Okay? So ask about any sexual concerns. Are you having any pain or numbness or weakness down into your legs, into your butt, down into your feet? Okay, moving into the mid-back, the nerves that come out of the mid-back, they go to pancreas, liver, stomach, goes down into kidneys, and also the muscles in the mid-back. Having any symptoms in those areas?
Yeah, my stomach is upset.
Oh,
Heartburn.
okay, heartburn. So when does that happen? Does it happen after eating?
Just random.
Just random. Okay, very interesting. How long has this been going on?
2 years.
Okay, all right. So we're making notes of that. We're keeping track of all those conditions. We're going to tie that in. Am I going to say that removing a subluxation is going to cure heartburn?
No.
Okay, Jason, I would never say that. People will, there's chiropractors that say that, so you are who you are. I will say it may benefit, it may help, okay? I also would give nutritional advice. I talk about a probiotic, drinking a lot of water. I talk about if you eat fried foods, drinking a lot of alcohol or any of those types of things. And we just delve into that stuff. The upper back, the nerves in the upper back go to the heart and lungs. Any difficulty breathing? No. Any heart palpitations? Ever have a cardiac event? How about the family? Any history of stroke, heart attack? Your father did. Okay, all right. So we're going to make note of that, okay, because there's going to be a genetic familial factor there. The nerves in the neck, they go into the neck muscles, of course, that can control hearing, sight, thyroid. Any issues with change in weight? Any history of thyroid issues for you or your family? Not at all. Do you wear glasses?
No.
Any hearing issues? No, not at all. Okay, so we've got a list. We've got a couple different conditions. Now it's more than just low back pain, right?
Dr.
We want to make sure.
When would you bring in like high blood pressure? Because a lot of people would that be in the heart or the neck?
Yeah, and if I didn't say it, I thought it.
Okay.
I meant to say that. I should have said it when I brought heart. Okay, so we're going to bring up high blood pressure. Do you have it? And talk about those issues as well. Now, do you guys do blood pressure and pulse in your practice? Does anybody do that? Anybody check blood pressure and pulse? You guys really should. Your license requires that you do that. Does your license require you to do that, Michael? Okay, in the U.S., you're responsible for it, so you should check it. You should get a pulse oximeter. You stick that thing on their finger. It checks their respiratory rate, pulse oxygenation, their pulse, everything. It's an important thing to do. I had a guy that came in last month. He was taking 40 ibuprofen a day. His low back pain a day. His low back pain and radiating leg pain was a 9 out of 10. His blood pressure was 220 over 180. Okay, so we sent him right to the ER. Okay, all I did was take his blood pressure. I don't even need to know what it means, right? It's the right move, okay? So they cleared him, they changed his med for his blood pressure. He came back, started into symptom care. A couple, 3 weeks, we had the symptoms down enough to start him into corrective care. Now he's off all the ibuprofen. Okay, he's taking fish oil. Super cool, blood pressure's down, right? So the pain brought the BP up. Certainly the ibuprofen may have had a factor. Those were all issues, but check blood pressure, pulse. It's an important thing. And you look good, right? Helps us look good in the healthcare community as well, because they're gonna say, a chiropractor check that, right? I mean, it's just a simple thing to do, and it's very easy to catch. And then what you do is something's abnormal, you punt, right? Get them to their GP or get them to the hospital. You don't have to manage it. Okay. All right, so we've asked all those questions, we talked about those things. Now what we're gonna do is move into an examination, okay? So we're gonna be doing an orthopedic palpation, which means touch and feel your spine and your joints and your muscles and how they move. Orthopedic evaluation, a neurological evaluation. We're gonna check the strength of your muscles. We're gonna check your reflexes, the sensation in your arms and your legs. And then when everything's done there, we're gonna go ahead and get the x-rays, okay? All right, so you want to do everything, of course, logically. Everything, yes, sir?
How long do you allocate to do all this?
The pre-consult, you should be able to do in about 3 to 7 minutes. So here's what I would do if I was a sole practitioner. My CA came in and did the tour, did the blood pressure, did the pulse ox, took the photograph. I come in and I do the pre-consult part. 340-degree curves, spine straight from the front, talk about the conditions, do the posture straight. That part can be 3 to 7 minutes, okay? What I can do then is say, I'm just gonna go check out on the floor with our patients. I'll be right back, give me about 5 minutes, okay? I've got a rule in my office, I call it the 10-minute rule. No matter where you are in my office, between departments, I never make you sit longer than 10 minutes. Okay, patients really appreciate that. So then I can go out, I can do an adjustment or 3, and then come back in and pick up.
So another question is, if it's a PI, are you going to do all of this?
Yeah, especially.
Especially.
Yeah, especially if it's PI. Yeah, I do more on a PI, right? Because there's more going on.
Yeah.
So tell me what you're thinking. Like when I go into the 340-degree curves.
2 things I'm thinking. Number one, they're more motivated to follow care.
PIs are?
Well, in my experience, they are.
Okay.
And secondly, if they come in with just cervical complaints, you may want to tie that in, but just due to time and so forth.
So I want to, because they're more motivated, I think what you're saying is you don't have to put as much of this time in.
Correct.
Okay. I get it. I do this anyways because PI is how they pay, and they're still my human being that I want to have an effect on for their entire life. Right. So when I get into the next day when I do the report of findings, I do CVP corrective care on PI if there's a clinical indication. And then once they're done with the PI, I'm going to make a 6-month or a 12-month or a lifetime recommendation for supportive care. And then they're going to have to pay for that on their own. So they still need to see the value. And in a way, it's more important to do it with the PI because the first part of their care isn't out of their pocket, right? Their only investment is time. So the health insurance patient or the private pay patient, they're paying right now, right? Like they have to be totally engaged. The PI, the first part's easy, and then you've got to convert them into paying, which we really want to do, right? Because it's better for them.
And you know there's several different types of PIs. You have you know that. You have the groups after money.
Right. I've got some languaging patterns that I use to try to filter out the BS, just besides malingering tests. And you know, they really perceive that this is that we're genuine and this is the real deal. I can really make sure we filter out that junk. Okay, so we're going to go into the exam. Now you want to do everything that you can do seated. So I'm going to do my reflexes, I'm going to do my dermatomes, I'm going to do my myotomes, I'm going to do all those things seated. Now the important thing is that we're close, we're touching, and then I'm conveying to him the results. What we do a lot of times as docs is we go through, we do all of our tests, but we don't talk to them about what they've got going on. Say it out loud. Wow, your reflex on the left is diminished. Okay, let them know that, okay? Wow, that's interesting. The sensation coming down this side of your leg isn't normal like it is on this side. You feel that? You're developing a kinesthetic relationship with them. You're tying in what you say to how they feel. Okay, really important. Talk through your results, okay? Don't say a little, don't say a lot, just say what it is, okay? I'm gonna come behind, I'm gonna do my ortho tests. I'll do everything that's provocative first. Head forward, tell them what the test means, okay? And then on the cervical, I want to do this test in this position next. The last thing I want to do is cervical axial distraction test. Does that give you any relief of your neck or your low back symptoms?
Yes.
Okay. Make sure you ask that question. This is a cervical test, right? It's for cervical trauma. So it either relieves pain and it's positive, or it causes pain and it's positive. If it causes pain, it's sprain. If it relieves pain, it's facet, a disc. But you want to ask them about the low back, because a lot of times this is going to give them relief. Do any of you have cervical axial distraction in your office? Anybody have that? Okay, a couple of us. Get this in your office. This is a really effective treatment to have. Doing cervical axial distraction, I don't care if you buy the Myers over the door hanger, right? But do this, because then you're going to let them know, wow, that gives you relief. Now in my office, I'm going to put them in UTS. That's great. You're actually a candidate for our spinal traction system. My office only has UTS, so that's the only thing they know. So in the universal tractioning system, we can put you into therapy. We'll actually do this with you today. It's going to lift the weight of your 60-pound head off of that area in your back where you're having all that pain. You'll actually get some relief today. Now, an important thing, does anybody adjust on the first day? Anybody adjust on the first day? Good. Obviously, we want to lift up the hood before we start wrenching on the car, and we need to do that by taking x-rays. We need to review the x-rays on the first day. We go over them with them on the ROF, right? So they know that, they're prepped for that. You may need to address it because a lot of patients want to get adjusted, but you can give them some treatment on the first day. You can do ice, you can do electrical stimulation, you can do cervical axial distraction, you can do something with them that isn't an adjustment, okay? So then they get some relief, they're happy that they got some treatment, and then you're gonna put them in a machine, whether it's an over-the-door hanger or if you have universal or whatever you have, you're gonna put them in a machine that ultimately will be the machine that fixes them. So they're in this machine that's making them feel better, they have success in that machine. Then when you move them into doing corrective care where you're gonna do a poke two-way, they've already got confidence in that machine. It's not like that machine here made them feel better, but then this machine sucks. This machine hurts, right? So there's an intention behind everything we do, right? The same machine made you feel better, but now we're just starting to pull you back the other way. Okay, so the next thing I'm gonna do is have you stand up. Now we did cervical range, the neck ranges of motion. Now we're gonna do low back ranges of motion. I want you to just bend down as far as you can and touch your toes. Get next to your patient in case they're unstable or they fall. Come back up for me. Place your hands on your low back right here. I want you to bend back as far as you can. Is that causing pain? No, not at all. All right. Turn your upper torso here. Checking the rotation. This is all just visual, you guys. Side to side. Okay, great. Make your notes on your range of motion. Ask if there's pain. Now we're in the coronal plane, so we can start our posture analysis. Now we can go to our XYZ. Now what you're going to do with them is you're not going to tell them their XYZ. You're going to say, okay, I'm looking at your pelvis is shifted to this side, and then you can come over and go, yeah, it's going that way, and then your spine is moving this way, it's going over to this direction, and then your head's shifted to this side. If this was a car collision, you can ask, was it a side impact, right? Did your head get knocked like this? Or if it was a rear end, was your head turned? That can cause a translation in your head. Tie all that in, okay? They want to hear what's going on. We want to give them something now. Have them turn to the side, face this direction. Talk to them about what you see in their posture, right? We can have translations along Z. We can have rotations around X. Call it out, touch them, point, show it to them, okay? Next, we're going to go to the table, have them lay face down. We're going to do all of our orthopedic tests that we do face down. We're going to do all of our palpatory exam. And then don't spread mayonnaise on them, okay? Don't do the light pussyfoot touching. Get in there and touch and dig, and then go, wow, that's a really tight muscle. That joint isn't moving the way it's supposed to. All the way down to the tailbone. Have them then turn face up, do your SLR, your Milgrams, your Braggarts, all of your face up tests.